Today I'd like to talk about fibromyalgia. Fibromyalgia is a syndrome of diffuse body pain present for at least 3 months, associated with fatigue, sleep disturbance, cognitive changes, mood disorders and somatic symptoms, symptoms which cannot be explained by another condition. Patients present with diffuse or multifocal pain. Onset of symptoms may be preceded by a period of psychological stress, an acute illness, a physical trauma, or the development of a regional myofascial pain syndrome. The majority of patients describe fatigue and non-restorative sleep, with increased sleep latency and poor daytime functioning. Patients describe changes in memory, verbal fluency, and decreased concentration and attention. Mood disorders coexist in up to 75% of patients with fibromyalgia. Fibromyalgia is associated with other somatic pain conditions, including irritable bowel syndrome, headaches, urinary tract symptoms, and facial pain, but it may also coexist with chronic autoimmune disorders such as rheumatoid arthritis and SLE. Whether fibromyalgia is a rheumatological, neuroendocrine, somatoform or psychiatric disorder is still hotly debated. However, abnormalities of pain processing have been identified at several levels in the peripheral, central and sympathetic nervous systems, as well as in the hypothalamo-pituitary adrenal stress response system. The prevalence of fibromyalgia is increased in family members of patients. However, environmental factors play an important predisposing role. Being overweight or obese with low physical activity levels, low job satisfaction, and a history of depression or early life adversity is associated with an increased risk of fibromyalgia. Diagnostic criteria developed by the American College of Rheumatology in 1990 relied on the identification of a certain number of tender points. However, revised ACR diagnostic criteria recognise the importance of associated somatic symptoms and the heterogeneous presentation of fibromyalgia. The Widespread Pain Index documents the number of areas in which the patient has had pain over the past week, with a score ranging from 0 to 19. The Symptom Severity Scale measures self-reported symptoms of fatigue, non-refreshing sleep and cognitive problems, as well as the number of general somatic symptoms. The score for the Symptom Severity Scale ranges from 0 to 12. Based on the revised American College of Rheumatology diagnostic criteria, fibromyalgia is diagnosed with a widespread pain index of greater than or equal to 7 and a symptom severity score of greater than or equal to 5, or with a lower widespread pain index of 3 to 6 and a greater symptom severity score of greater than or equal to 9. Initial clinical evaluation of patients presenting with widespread pain symptoms aims to outrule conditions such as hypothyroidism, early inflammatory arthritis, polymyalgia rheumatica, myopathy, multiple sclerosis, renal or hepatic failure, or adverse effects related to medications such as statins, bisphosphonates, or aromatase inhibitors. Physical examination, including neurological exam and musculoskeletal exam, is usually normal in fibromyalgia, except for the presence of touch allodynia. Investigations should be limited to full blood count, ESR, CRP and thyroid function tests, except in the presence of clinical findings requiring exclusion of other medical conditions. Treatment of fibromyalgia requires a multimodal approach. Non-pharmacological strategies are at least as effective as pharmacological therapies. Education reassures patients that physical activity is not harmful, improves coping skills and encourages patients to take control of their symptoms. Patients should be reassured that though symptoms in fibromyalgia vary over time, fibromyalgia is not a progressive condition. Psychological interventions, including cognitive behavioural therapy, improve self-efficacy and pain-related behaviour and help patients to cope more effectively with their symptoms. Exercise, including aerobic exercise and strength training, are associated with improved pain, improved fatigue and quality of life. The combination of cognitive behavioural therapy and an aerobic exercise program is associated with long-term improvements. Meta-analysis and systematic reviews support the efficacy of antidepressants and gabapentinoids in fibromyalgia, with improvements in pain, fatigue, sleep and quality of life. Initiating treatments with low doses and gradual upward titration improves medication tolerance. In clinical practice, opioids may be useful in selected cases, but treatment should be associated with improvements in pain and function. Tramadol is the only opioid which has been studied in fibromyalgia. Generally, use of strong opioids should be avoided. Fibromyalgia is a heterogeneous condition, and treatment in each case should be tailored to the most prominent symptoms. Interventional treatments do not have a role in the general management of fibromyalgia, but can be useful for focal complaints. Untreated mood disorders are a barrier to rehabilitation and require treatment with antidepressants or behavioural therapy. Though fibromyalgia is not a progressive condition, many patients struggle to cope. Patients with progressive disability as a result of their symptoms are best treated in a multidisciplinary treatment programme, including educational, psychological and exercise components.